Hi everybody and welcome to today's webinar. My name's Kate Halliday. I'm Executive Director of Addiction Professionals. I'll be chairing the webinar today and I'm really pleased with this. It's been massively popular. Got quite a lot of people who have signed up for this webinar. I'm not at all surprised why, because we have 4 really fantastic researchers who are going to be talking about the impact of the pandemic on people who use drugs and whether we can draw lessons from this. And I think, you know, this is a really good time to begin to look at lessons learned, and we've got some high quality speakers here. So it's great that so many people have signed up. This is part of our CPD premium membership package. We'll provide a little bit of information for you on that if you're interested in that. It is normally paid for. We provide webinars and crises research, but we've opened this one up for free, just to give people a bit of a taster, and we're really pleased people have been so interested. So the format of this webinar is we have 4 fantastic presenters. We have Professor Catriona Matheson from the University of Stirling. We have Dr. Jo Kesten from Bristol Medical School, who's a research fellow there. We have Dr. Jenny Scott, who's Senior Lecturer at University of Bath. And we have Dr. Emmert Roberts, who's a Clinical Research Fellow at the National Addiction Centre. And they're each going to be talking about a piece of research that they've carried out in the recent past around activities during the pandemic. So this webinar is going to be recorded. So if you want to catch up with it again, it will come up on our website in the next few days. And each presenter is going to talk for around 15 minutes. There'll be a chance to put a couple of questions to them after their presentation, but then a longer session at the end where we can ask as many questions as possible. I can put as many questions as possible to the panel. So please use the chat function. Please use the questions and answers to ask questions. And I think that is certainly enough from me, because we have so much to get through. This webinar is going to be an hour and a half today, around an hour and a half. So there should be plenty of time for questions at the end. So definitely enough from me now. And I'm really delighted to introduce our first presenter, who is Professor Catriona Matheson. So over to you.
Hello folks, and thank you. I just want to check that you can see my screen okay. I'm going to go to presenter view, and sorry, I'm just trying to get onto that proper presenter slideshow view. There we go. So I hope you can see that. So lovely to be here everyone, another day, another webinar, and here we are still 2 years later, almost exactly 2 years since COVID started to raise its head and affect our lives so massively. So what I'm going to talk from the Scottish perspective about some research we did based at the University of Stirling and also with colleagues at the University of Edinburgh. And that was to understand the impact of COVID from the perspective of people who use drugs, but considering also the markets, the illicit markets and services. Just to recognise and acknowledge all the team, very much a team effort. And there's a team at University of Stirling who focused on doing the work around services and health services, and at University of Edinburgh who looked at the drug markets. And we were funded by the Chief Scientist Office of the Scottish Government. Now, before I go into the full research findings, let's just go back to what we thought and understood. Our perspectives have all changed a bit. Now we're 2 years on and older and wiser. But at the very beginning, we were particularly concerned about the vulnerabilities of people who use drugs to severe infection and to COVID-19 in particular. And this is because this group of people we know have many chronic health conditions, things like respiratory disease, cardiovascular disease, which were particularly high risk for COVID and experiencing COVID more severely. There's also a number of other comorbidities that this group can have, and people may be immunocompromised. And then there's these other factors, social factors as well, around homelessness, which make people maybe be congregating more in homeless shelters and other locations, and the deep social exclusion that this group faces as well, lack of access to healthcare and other support services. So these were very high risk factors, and we were very curious and interested to see if and how this might make our particular group more at risk. And alongside this, in the early days, going back to March 2020, when we started thinking about this research, we were aware that treatment services were already planning to have more take-home doses, so there would be more access to medication. There was a lot less face-to-face contact. Staffing challenges were a problem already, starting to emerge as people were isolating and being affected. But pharmacies were remaining open, and that was albeit in a slightly different model with controlled access to reduce the infection risk. So that's the background. I'm going to just also share with you a little bit of background on data from Scotland on a national level that we were able to collect. And this, if you look at the orange dotted line here, you will see the period of time that we were of the pandemic, the start of the pandemic, compared to the blue line, which was the year before. Now, if you look at this point here, just after the first lockdown started, there was a big reduction in our hospital attendance at accident and emergency for drug-related admissions. That then increased in June 2020, and that was a period of time when people were coming out of the pandemic and out of the initial lockdown, not the pandemic, sadly. So I just wanted to share that with you to see that there was an impact at certain service delivery service provision. Another impact I want to share with you from some national data in Scotland is around naloxone supplies. And again, if we look at when the pandemic started, just after that, there was a big increase in naloxone supplies. That's the red line for 2020. And that was because people would be given naloxone home with them, and there was a big push to make sure that happened. And then later, just around April time, there was a change in the guidance from the Lord Advocate, which is the Scottish head legal officer, who allowed more naloxone to be supplied through non-drug agencies. And in fact, it increased considerably by 31% over that year. So that's some background. Now to the research. So the aim of this project, as you'll understand, is about looking at the health impacts of our social response to COVID on people who use drugs. The research questions, specifically, we're looking about how social response can affect the illicit distribution, availability of harm reduction, and also treatment and recovery support services. And we did this by looking at some quantitative data from sources about drug markets, but also interviewing people who use drugs from different parts of the treatment and support system. So the component looking at health impacts, we interviewed 29 people, 13 women, 16 men. The age range is quite a sort of standard age range for this group, and we identified them through third sector and homeless hostels across the Central Belt and Dundee in Scotland. We avoided NHS services to avoid the need to have to go through NHS ethics mostly, because it was a rapid piece of work. We also did some data collection from exploring the drug markets, from online surveys. We had data from Police Scotland, from Wedanos, that's a drug checking service in Wales, and some data from the darknet crypto markets, and analysing our interview data. So, on to some findings then. A little bit about the findings around the markets. So yes, we experienced really a splitting in the markets, and this is really around people who have access through internet to accessing drugs and ordering online, and to those who are more used to the street supply of drugs and relying on street dealers. There was an initial supply shock And that was really for about a month, only a month. And after that, supply returned to normal levels. There was some reduction in use, certainly for some people, and people were seeking some greater variety in the drugs that they used. Less in this party context because people were isolating and were under quite a strict lockdown in that early phase. And people were using obviously more at home and less in other market type situations. And dealers were certainly using cutting of their products and credit to try to maintain their market. And people were experiencing being bumped. So what we'll do now is focus really on our more vulnerable sides, people who were relying on the street supply of drugs. So there was vulnerabilities really coming through quite strongly. As you'll see from the quote here, these are both about people who were having difficulty with supplies and change in supplies. And the first quote, I'll read this one to you. It was harder, to be honest, to access drugs. A lot of the dealers couldn't get hold of supplies, this is in the early days, which meant we were having to go further afield to find the drugs, which means we don't know the people we're getting them from and don't know what they're cut with. And prices could go up as well. And then the second quote is from somebody who was street homeless and describing, the vulnerabilities of being in that position, but also being bumped and being given paracetamol instead of what he was expecting. And the knock-on effects of that. So if we then look at service access, there was, we've already seen that we know the naloxone exposure and the distribution of naloxone was increased considerably. So there's a few quotes here that really just illustrate that this was in fact the case. I'll not read them all out to you, but what we know is that there was also some targeted outreach for those who were most at risk, and there was a lot of posters and things up around various services to really try and make sure people were getting access to naloxone. So that gave us some validation of what we thought was happening at service level and what was being experienced. And then when we consider substance use treatment services, there was rapid access in one site in particular where they really made an effort to get a prescribing nurse to go out and fetch people and identify people where she knew they were and provide some, try to get them onto a prescription. And this quote really describes that, how she basically did a drug test round the back of a shop where somebody was begging, and she got him onto a prescription. We also had an example of someone being started on a methadone script in a graveyard where they were basically kind of effectively living. We know there was changes to the dispensing arrangements, and this had a couple of implications for people. For some, it was positive. For some, it was about trust. And this quote here gives an example of that. It's about being trusted. And this person certainly didn't see the point to worry about taking it all at once. That wasn't really on their agenda. However, that wasn't the case for everybody. There was also negative implications for people having large quantities at home, as this quote illustrates. This person was unfortunately tempted to take more. And the variable contact we had with prescribers and support staff was described from different sites. And then in terms of general health and care services, people were reporting a range of coexisting health conditions. But like the rest of us, everybody was experiencing that lack of access to general health care. And for some people, of course, this is a group that have more coexisting health conditions than other people. And this quote here acknowledges it's a lady who had a number of problems with kidney, with her heart, and was really worried about it and struggling to find out quite what to do. Eventually did get access to a doctor. The other thing that came up quite strongly was around dental issues. Dental issues are common again in this patient group. And of course, the problem is when people have access to drugs and the drugs that have an anaesthetic or an analgesic property, this person here says, I only knew one way to get rid of the toothache, and that was use, and I used a lot. And eventually this person did phone the dentist. But at that time, dentists were often just doing extractions and not much else. So dental pain control was a problem in particular. A key theme that came out of our work was around digital inclusion or exclusion, which is the other side of it, of course. Now, this came in two forms. In Scotland, we had a really big push to get either data to people so that they could access services if they had devices, phones or tablets already, but also giving out mobile phones to others who didn't have a decent smartphone that could be used for face-to-face, digital connection with their services. So the first quote here is about, although they had Wi-Fi, they didn't have data, but by getting data from their service, it meant that the little boy was able to use his tablet, and she could also then get onto some of the support groups on WhatsApp. But this didn't work for everybody. And there was an older gentleman, 55-year-old man, who said, I'm not a phone person. It's hard to let people in, you know, especially over the phone. So for some it's easier, but for some people who are not comfortable with this, who are not comfortable communicating, but even less so through technology, this was not particularly helpful. And we can't leave people like that behind. But in terms of recovery support, so people who are in recovery and maybe using some of the OA type groups, there was a really kind of quite positive aspect to the 24/7 access that you get online. And this person here in the quote on the right-hand side is describing how they were able to tap into a Zoom meeting and found themselves in a meeting in Boston. So the 24-hour access had its potential benefits for some people. So just to finish up and to summarise, what we found, and I've only given you a snapshot of it, there is a publication, by the way, just imminent on this work and also a report. But what we found was that some people use lockdown as an opportunity for change, but there was increased vulnerability of both drug-related harm, but not, interestingly, COVID. COVID did not really seem to feature, and that has been borne out in subsequent data around COVID deaths. It's not particularly come through as the risks that we were anticipating. Harms are more concentrated though in our more vulnerable and isolated groups. So people who have reduced access to service, this digital divide really came through, and users with reliable access to digital connections were far better able to manage their supply risks, but also access to services. So we saw evidence of mitigating factors that came through about increasing naloxone access, maintaining injecting equipment. There was overdose response pathways in some parts of the country, and the access to mobile phone and data certainly was beneficial to some. So those practical solutions were very evident. So I am going to finish there and hand back to you, Kate. Try to stop sharing my screen now. There.
Thank you, Catriona. That was really interesting, and you know, I think it's described what a lot of services have experienced during the pandemic. I do have a question for you. If you've got time to answer a question before we go on to the next presentation. Someone's asking about whether there was an overlap with alcohol with regard to the hospital admissions.
Well, I don't have the same data off the top of my head on alcohol, but I believe, without having that to hand, that there has been certainly more alcohol use. Whether that's transpired into alcohol admissions, or we had a reduction, of course, at the start, I don't know, but there was certainly, we know there was less any admissions generally, because people were not wanting to phone ambulances if it was not for COVID related issues. So I can't give a full answer to that, I'm afraid.
Okay, thank you. I think there's quite a lot of chat going on, and we are going to go straight on to our next speaker. And I'm really pleased to introduce Dr. Jo Kesten. And it's over to you, Jo.
Yes, so I'd just like to start by thanking addictions professionals for organising the webinar as well. So for people who weren't here at the start, I'm Jo Kesten, a research fellow in the NIHR ARC West and the Health Protection Research Unit in Behavioural Science and Evaluation at the University of Bristol. So I'm a qualitative researcher with an interest in developing and evaluating public health and health service interventions, and an interest in harm reduction among people who inject drugs. And today I'm presenting findings from the LUCID-B study, which stands for Living Under Coronavirus and Injecting Drugs in Bristol. And this was a rapid study, qualitative study conducted in Bristol in response to the pandemic and concern about the disproportionate effect that it would have on the lives of people who inject drugs. So just to give you some context, Bristol has the highest mortality rate for drug-related deaths in the southwest of England. And I hope my presentation complements and supports the findings that Catriona presented from Scotland and the work that Jenny will present conducted in rural areas shortly. So I'd just like to acknowledge the team behind this work, which is led by Lindsay Hines, and also to say that we're very grateful to Bristol Drugs Project for supporting this work and ensuring we could conduct it so quickly and rapidly. So as we've heard, a lot of services had to adapt during the pandemic in response to the first lockdown. So for example, nationally, we know that essential face-to-face services continued, but with social distancing measures, and all other interactions were conducted remotely. In Bristol, the fixed site needle and syringe programme, which is run here from this building with a pink door, switched to a doorstep needle and syringe programme service, so people could still access injecting equipment, but they couldn't come onto the inside the building. And some pharmacy needle and syringe programmes were withdrawn at this time locally. Oh, I see the subtitles working, that's good. And in response to some of the barriers to accessing harm reduction services, BDP, Bristol Drugs Project, rapidly increased their outreach services, including going out to homeless accommodation and also expanding their needle and syringe programme home delivery service. And they also began an opioid substitution home delivery service for people who were clinically vulnerable and shielding, so staying at home during the lockdown. There was a local effort to start people rapidly on opioid substitution treatment and ensure as many people as possible could be started on it as needed. And as Catriona mentioned, there was relaxed requirements for supervised OST consumption, and following risk assessments, up to 2-week take-home supply was offered. And locally, some mutual aid groups offering recovery support were stopped or switched to telephone or online delivery. And the local inpatient detoxification unit also closed. And this was all at the beginning, I should say, all at the beginning of the first lockdown. So there was real uncertainty around how these changes would be received, what the impact of them might be, and also calls to involve people, so clients or service users, to understand their views on these changes and to feed that back to services. So the aim of our study then was to really understand overall people's experiences of the pandemic and to try and use the findings to rapidly inform service delivery through interim reports, and also long-term to think about how this might inform policy and practice in the future or in response to similar situations. But specifically, we aim to understand challenges relating to the COVID-19 public health measures, views on changes to services, and perceived effects on drug use patterns and risk behaviour. So what did we do? Well, Bristol Drugs Project helped us recruit participants between June and August 2020, and we conducted telephone interviews. So BDP staff recruited people when doing their home delivery service, their street outreach, and their doorstep service, so their needle and syringe programme. And anyone who was interested in speaking to us would then sort of put in touch with us. And our inclusion criteria were people who were 18 or over, who were injecting at the start of the first lockdown, and were able to conduct the interview in English. And so we interviewed 28 people who were aged 25 to 54 years. 9 were women, and the majority were receiving opioid substitution treatment and were living in temporary or emergency accommodation, including as part of the government's Everyone In scheme, which was a national effort to house people who were street homeless at the start of the pandemic. So what did we find? Well, the concern about COVID-19 infection really varied within our sample. So some people were not very concerned, partly because they didn't know anyone who had it. And at the time in the southwest of England, there were quite low case numbers. So, you know, perhaps the perception of risk was lower as a result of that. There was also some denial about becoming infected and believing that perhaps you have immunity through a previous infection, such as the flu. And there was also some people expressing a kind of fatalistic view that everyone's going to get it. There's not really any way that you can avoid it. And people talked about having more pressing issues, such as existing health issues or their drug dependence being a greater concern than COVID. And also it was noted that the symptoms of COVID-19 can be quite common among this group of people. So for example, a persistent cough. But others were quite concerned about COVID-19 due to pre-existing health conditions and feeling this perceived vulnerability, and also being concerned that it was very difficult to follow social distancing measures when around other people who use drugs or when buying drugs from dealers. And while buying drugs is often quite a hidden and private activity, the pandemic and the lockdown meant that it was made quite visible if you were out on the streets when you were not supposed to. So being able to follow the social distancing measures was made more difficult, and there were kind of these structural barriers. And there was quite good awareness of the social distancing guidelines and the public health guidelines. But again, people face structural barriers to following these, particularly when living in quite crowded temporary accommodation or hostels. So people describe this as like a fighting a losing battle. So a major theme in our data was this idea of sense of support, and people really valued services continuing to provide services and their staff to continue providing support at this time. And so some of the changes to services were valued and seen as improvements, but some were seen as less than ideal. So, for example, changes to remote forms of communication were repeatedly described as just not the same. It was difficult to know if the person you were speaking to could hear you, or that feeling of not really wanting to open up to someone that you can't see, that you're not sitting in front of. And services home delivery of needle and syringe programs was seen as more convenient, as accessible, and as overcoming some of the barriers to accessing equipment at this time, because, for example, in pharmacies, they had limited opening hours and very long queues due to social distancing, and it made collecting equipment and collecting your opioid substitution treatment more visible. So the home delivery was appreciated for that. However, people were were kind of reluctant to have open conversations about their drug use during a home delivery, and so that meant access to that kind of support became a little bit more limited. And the same for the doorstep needle and syringe programme. It removed this privacy and sense of anonymity. And there were reports of drug treatment housing continuing warnings and punitive measures for positive drug test results, despite reduced support for substance use at this time. And so a kind of reduction in access to group work, for example, meant that people felt they couldn't connect with others as well. And there's this quote here about, they say the opposite of addiction is connection, but how are you supposed to connect with people when you're not legally allowed to do that because of the lockdown restrictions? And I won't, just to say as well, I won't go into the changes, the views of the changes on opioid substitution treatment, because Jenny will go into that in detail in a moment for us. And so another theme across the data was a sense of loss, and there was this really pervasive sense of loss in our data set. Firstly, a loss of routine and income, so there was a huge disruption to patterns of normal daily life. And people described a big part of their day being earning and buying drugs. And with the pandemic, they suddenly found that they couldn't do a lot of the activities that they were doing before. And so this resulted in a lot of boredom, kind of time to ruminate, and it had a negative impact on mental health. And although one participant described accommodation providing kind of activity packs, there was a really strong desire for more activities to structure the day and address this sort of issue of boredom. And sources of income were affected during the pandemic for many reasons, with job losses, fewer people being on the streets during that first lockdown meant that generating income through begging was very difficult, and the public were described as being very reluctant to come and give money to people, to put money into your hand. They were standing at a distance, they wouldn't stop, and this really enhanced feelings of felt stigma for individuals. And there was also a real sense of a loss of connection to friends and family. And as I said, this created a sense of, impacted negatively on people who already had pre-existing mental health issues, and a kind of greater time spent at home. And sadly, for many people, or for some people, this didn't actually have a great impact on them, because they described already being quite isolated pre-COVID. And so the lockdown didn't have a huge impact on their lives and the amount of people they were seeing. So loss of connection also related to communication channels being affected. So without having as many contacts with people during that first lockdown, informal information sharing between peers was impacted. And so people described not actually being aware of the changes to services or finding it difficult to work out how services were being provided. And for people who were particularly vulnerable, people who were street homeless to begin with, some talked about not having access to phones or access to the internet. And this again made it very difficult to access services at this time, particularly where a lot of services weren't seeing people in person. At least initially, it required a phone call, for example, speaking to a GP or a doctor. So a local scheme to provide phones was seen as really vital at this time. And in terms of impacts on drug use and injecting related harms, we saw a range of changes reported. So some people described increasing their drug use, while others described reducing it. And for some, not being able to access their income in the usual way resulted in a positive change because they were already quite motivated to stop using drugs as much, and that sort of helped them along in that way. So there were some changes reported in terms of frequency of drug use and the amount used and the type of drugs. So impacts on the drug supply and the drug market meant, and also income, meant that some people looked to use more available drugs or more cheaper drugs, including spice. And there were also some reports of increased infections and abscesses and health problems like this, caused by a reduction in access to or barriers to accessing injecting equipment, but also changes in drug use patterns and type of drug used. So overall, COVID-19 presented significant challenges for people who inject drugs in relation to service access and loss of connection and routine. And while rapid adaptations to service delivery, aiming to try and reduce the risks of COVID-19 infections, were appreciated, and some changes were acceptable, for many, the pandemic worsened already precarious and isolated lives. So we're now 2 years on, but I feel that many of the implications from this study are still very relevant today. Firstly, adopting innovative approaches to reaching people who inject drugs, as I've shown in this presentation, to try and maintain and increase coverage of services like needle and syringe programme, are particularly important for reducing the harms of injecting drugs when contact between individuals is limited and people are less able to pass information verbally. And I hope I've highlighted that harm reduction services, which many of you will be delivering, are more important than ever. And there's this real need to support people who inject drugs holistically and to have joined up cooperation between different service providers and sharing of learning to help address issues that the pandemic caused around reduced income, housing access, and difficulties managing mental health and drug use. And while no one is suggesting the pandemic has been a good thing, it perhaps presents a window of opportunity to rethink policy and practice. So, for example, considering the evidence around changes to opioid substitution treatment, as Jenny will talk about more. And as Catriona said about digital exclusion, if changes to remote service delivery are maintained or scaled up, it will be really important to ensure that people aren't digitally excluded and to provide more intensive support where needed. And I just finish there with my acknowledgements and pass back to Kate. I hope that was okay.
Fantastic, thank you, Jo. Really interesting. We've had a few questions come in, so I'm just wondering before our next presenter, it could be that Jenny's going to cover some of this, but somebody's wanting to know what feedback you receive from service users who are trusted with twice weekly or weekly collections from the start. And is this something we could adopt moving forward out of COVID to prevent some of the barriers we find from people restarting on OST?
Thanks. I think that's a really good question. I don't want to anticipate what Jenny's going to say, so perhaps I'll leave that one for Jenny. But we did have findings around people's perceptions of changes to the treatment, which are presented in the paper if you wanted to read what we found in our study. Great, and maybe we could have a discussion at the end as well. Yeah. There's another question about specifically your research, and somebody's wondering, do you think many participants were excluded due to the criteria you had, for example, individuals who would need interpreters? They've given as an example. That's a good question. So we were relying on Bristol Drugs Project staff recruiting people to the study, and so they had to engage with the staff. They had to really be receiving support through BDP Yeah, in order to hear about the study, which is a limitation in the sense of there might be people who aren't accessing services who had very different experiences. In terms of interpreters, it's a good question. And I suppose we are limited in terms of who we could speak to, in that sense that they had to be accessing support from BDP or at least engaging with BDP. Yes, it's a really good question. I'd like to think about a bit more. Yeah.
Great, thank you. All right, well, thanks again, Jo, and we're now going to move on to our next presenter, and I'm really delighted to be welcoming Dr. Jenny Scott, and I think many people will be familiar with your work, Jenny, so I'm really pleased to hand over to you.
Thank you, everybody. It's lovely to be part of this webinar. As Kate said, my name's Jenny Scott. I work at the University of Bath. I'm a pharmacist, and I'm going to talk to you about this work that we did in rural areas and explain to you what we learned. This is our team. This was called the What Cost Study. You recognise quite a bit of Lucid B overlap, and really the study was conceived out of some of the early findings from Lucid B. It was funded by the University of Bath. We didn't have external funding for this, and supported by NIHR ARC West, who have given some platforms for publicity. It's also supported by Turning Point. My disclosure here is I'm also a clinician. I work as a specialist prescriber with Turning Point. So this also connected closely with my clinical work. So just to give you the background, we were interested to know how people in rural areas experience the changes in drug treatment in the pandemic. A lot of research around drug treatment is based in urban locations. When you look, there is some work in rural areas, particularly from North America, but by and large, people are recruited from urban centres. And I know as a clinician who's worked in rural drug and alcohol services now for about 13 years, that compared to when I was based in Scotland and in a city, there are big differences in some of our clients and experiences they have and challenges. So we're interested to know, has there been any particular impact of the rural locations on how the pandemic's influenced them? And as I said earlier, it really was tagged on to Lucid B, and came out of practice experience as well, and discussions I had with colleagues and our central team at Turning Point about how are these changes that we're having to implement very rapidly. And we would never in our wildest dreams have imagined implementing even a few weeks before we had to, how are they bearing out in our patient group? Particularly, our clients are fairly isolated sometimes. There are issues around how the pandemic impacted on transport. There were no outreach services, certainly initially, and geographical impact as well. Such as Jo mentioned, the Everyone In initiative that didn't always sort of seem to bear out as planned in a rural area, because sometimes, for example, people were put in hotels 20, 30 miles from where they were sleeping rough and completely disconnected from any contacts they had. So that's the background. Overall, we aim to understand, how people in opiate substitution therapy in rural areas had been impacted by COVID and how they'd responded to the changes in service provision and treatment. I'm going to talk today really about that focus on accessing care, not the wider stuff around the impact of the pandemic on them. This was another qualitative study using thematic analysis, and we really wanted to understand both the practical stuff, like what happened when you went to fortnightly OST provision, and also the perceptions and experiences of people. What was it really like for them? And it's quite an exploratory study in that sense. And there's our ethics and governance approval at the bottom. So what we did was we recruited from 3 rural drug services, 2 in the southwest and 1 in the east of England. I think it's important to say at this point, the people who were recruited from my own clinic were interviewed by Hannah, who you saw on the earlier screen. I didn't have anything to do with their recruitment or collection of data, and didn't, so there wasn't that kind of clinical conflict. We used the key workers or termed recovery workers as gatekeepers, relied on them to identify people, approach them, give them information about the study and seek consent to pass on their phone number to us. And then myself or Hannah contacted them about trying to identify a mutually agreeable time for interview. So we made 5 attempts to recruit people before we decided that they weren't willing to participate. So we had consent to contact 33 people and eventually managed to recruit 15. And this was at a later date, as I said, from Lucid B. It was kind of in the months just after, so from October 2020 to April 2021. I think it's probably important to acknowledge that there were real challenges in the recruitment. I think particularly the staff were incredibly busy and trying to keep it on the radar and give them this extra thing to do along with everything else the pandemic threw at them was definitely a challenge. So who took part? Well, 8 women and 7 men. Age range you can see here, the average age is 43, the youngest 31. Up to 56. And most of those people were what you might consider quite stable in drug treatment. Only one had come into drug treatment, and not for the first time, but he'd come into this episode of treatment during the pandemic. The rest had already been in treatment prior to the pandemic. Most had their own accommodation or were living with family and were at no risk of or unlikely to be at risk of homelessness. But 3 people were homeless. One was living in his car, and one was in a tent or sometimes in a car, and another one was with friends. And for various reasons, everyone in had not they'd not been eligible, not suited them. In terms of their location, we asked people to self-describe whether they were in a remote rural location, a village or a town. 5 of them were in that remote rural category, a couple in a village and 6 of them in a town. Not to say that the towns are necessarily well connected with other towns, and the counties are quite large and the drug services dispersed across them, but not many outlets. And in terms of the treatment that they were in receipt of, 12 were on methadone and only 3 were on buprenorphine. So talking to really about drilling down to how people experience the changes in service provision, one of the central themes is this sense of feeling cut off and unheard, and amplification of what was already quite socially disconnected lives. People talked about being frustrated about the barriers to accessing services. And one of the things that came out quite strongly from our interviews is the importance to people of their key worker and that connection. And these people who were already experiencing difficulties were struggling with the sort of emotional impact of having that disconnect. People talked about worsening anxiety, worsening depression, feeling it was really difficult to try and make contact or to try and seek any support. And that intersection between those pre-existing struggles and the difficulties they had in the pandemic was quite evident. They weren't in a good place to start with, and it put them in an even worse place. And I think that was echoed in what both Catriona and Jo said already. But a quote here from someone just to try and illustrate that to you. She said, it hasn't helped me at all, the lack of contact and that, because as my mental health deteriorated, the thought of using drugs was coming in. And when we were going through regular reviews in that, as in face-to-face with our key worker, that's a deterrent. We have to give a test. There was none of that. And she talked about how she had used drugs for the first time in quite a while because of the impact of the pandemic on her mental health. And then again, echoing what we've heard from the others about digital poverty, the definite disconnection there, linked to really not being able to navigate or not having access to the equipment that would facilitate connection, particularly with key workers. So you've got somebody here talking about, you know, just he can't do that. He's not got a smartphone. He hasn't got Wi-Fi. He hasn't got access to these things. And then there was also a sense from these participants about not being heard, even if they could make contact. So the sense that it's harder to interact on the phone. It's easier when you can see someone's face to open up, to share your thoughts, to talk about how you are and the things that are impacting on you. And that seemed to give a real sense of feeling even more disempowered in that relationship they have with the drug service, and again reflecting what we've heard already. But there's a contrast to this, and the second theme around this is quite in contrast, because what we identified was that people who in a sense have, whether you like the phrase or not, recovery capital, there seemed to be an augmentation of that with the switch to digital platforms, telephone platforms, the switch to how services have been delivered. And we heard consistently about it fitting better with people's lives. People talked about being able to get on with their life, not having to spend so much time engaging in drug treatment, or jumping through hoops was a phrase someone used, to get the prescription and to access support. There's a quote here also from someone, and another sort of aspect to that was some people really felt not much had changed. You know, it doesn't make much difference whether it's a telephone call or face-to-face. You know, I'm getting the time, I'm able to be heard, I've got contact with someone, and that to me is enough. That's what I need. So this was really in quite contrast, but this was a group of people who life seemed to be going okay anyway. You know, they were stable on the prescription. Many of them were working or had activities they engaged in, and they certainly felt that there was a real convenience, and that intersected sometimes with you know, not having to travel. For example, rural travel can be quite tricky. People talked about now bus services were a skeleton service, how, you know, they were grateful that they could just pick up the phone and engage. They didn't have to do a sort of 3-hour round trip for a half-an-hour appointment, or they didn't have to navigate complex and not very often timetables. So that was the kind of headlines around how people perceived the changes overall. I'm just going to drill down a bit on some of the practical stuff around particularly medication access, because I felt that's something maybe this audience would be interested in. I mentioned how the key worker relationship was so key. That wasn't the case for everybody, but I think overall it came across strongly that key worker relationships were really important, but people recognised the importance of having to engage in prescriber appointments. And this, of course, is important for ongoing maintenance of prescription or any changes to prescription. So people were grateful for telephone appointments. They felt that it was less likely they'd miss an appointment. It was easier to answer the questions that needed to be answered in order to maintain your prescription. So this particular person here sort of highlights how important the prescriber is to them, and that's who they want to engage with. But as I say, and many people, it was also the key worker. The key worker was the most important person. But broadly, people were very happy to have had telephone appointments. We asked about pharmacy access, which Catriona mentioned. People were very accepting of the inevitable long queues, and several people talked about, because they were regular in the pharmacy, because staff knew them, they were given priority treatment. They didn't have to wait in those long queues. Some did, but not everybody. So, you know, we talked about here, someone's on first name terms with the pharmacy staff. They stick their head near the door, let them know they're there, and they bring the medication out even if there's a long queue. That was quite a common occurrence. And the other thing that struck us was, but I suppose as you might expect, most people had chosen a pharmacy that was close to where they lived, as opposed to the clinics, which are often quite far away and several bus trips or a different part of the county. So people talked about, by and large, pharmacy access was okay. You could walk there, but we had a smaller number of people reporting about some of the challenges around getting buses. And this particular person here who talks about, I had to get a bus from where I was put. He was one of the people that had been put in a temporary hotel in a different location to where he normally slept rough. And he talked about it was an hour and 15-minute journey. And if he missed the bus, the last bus was 5:15 and he wouldn't be able to get back to where he'd been put. So he had missed some pharmacy pickups, and he talked about not wanting to sleep in the streets again, just to get his prescription, because he felt now, life had improved so much by having accommodation. So he was having to choose at times between getting his prescription and having a roof over his head. In terms of the weekly or fortnightly supplies, I think it's not a surprise that most people had found that very welcomed. There was a sense of greater freedom and flexibility. People talked about going away, going to visit family, being able to manage their employment better, being able to do things they liked, being able to go outside and camp, etc. By and large, our cohort had been on takeaway medication beforehand, but not weekly or fortnightly generally. I think one person had been on weekly beforehand. Most people had managed well. We had one person who reported not managing well and taking too much in one go, and telling the service and being put back on daily supplies. But by and large, it was really, really well received. We also asked about dispensing in daily bottles, because partly through this study, there was a drug-related death in one of the services where the coroner had ruled that dispensing methadone in one big bottle had contributed to that death. Most people were receiving daily bottles. There was mixed views on those. Some were grateful for them. Some thought it was just a bit of a hassle, and they didn't like lots of little bottles clanking around in their bag and worried about breaking them on the way home, etc. But there wasn't strong objection. It was just a comment. We did pick up a couple of people who'd made mistakes in measuring their own methadone from large bottles. One had taken too much and one hadn't taken enough. So in conclusion, what can we learn from this? So I think what we've shown or put a bit of a spotlight on is that for people who are already struggling, the pandemic worsens things. It worsens their isolation, their feelings of disconnect, and their ability to really feel heard by their key worker and by the service providers and have their needs met. People whose lives were more on track, if that's the right way to put it, had really quite benefited from having the reins loosened, if you want to call it that, or having less demands on their time from the drug service. And pharmacy access was by and large acceptable. And we haven't come across any big issues with managing weekly or fortnightly supplies in our stable cohort, although some mistakes that I think we can reflect on around practice and advice given to people when they do have big bottles given. We're actively trying to discourage the dispensing in large bottles. So what can we take away from this? We need to think about, and certainly the feedback's turning point is, we need to think about ways to sort of identify and support people who struggle and prioritise maintaining engagement with them. We need to think about how we can make care a bit more bespoke to the individual and where they're at that point, giving people choice in how they receive that care. And just last to note, the challenges of undertaking research in a pandemic. I think we found recruiting people was a challenge, keeping it on people's agenda, and that cold calling from someone you don't know to talk about something very personal, I think is probably a factor in the number of people who initially said yes and then changed their minds before they actually spoke to us. And that is everything I wanted to say. Thank you very much for your attention.
Fantastic, thank you, Jenny. Really interesting stuff, and I think you certainly began to answer the question that I put to Joe earlier there about the feedback from clients who are perhaps reducing their pickups. I mean, part of the question was, is this something that you think, well, the panel perhaps thinks that we could continue post-COVID? And I don't know whether you picked anything up from your research or in your own practice, but whether there's been a relaxation that will continue.
Will I say something on that first? I mean, I think there's a lot to unpick. I mean, qualitative research is as these studies have been, is really important to understand people's perspectives and where they're coming from. But we also make decisions with data and numbers as well. And I think, you know, we need to look at drug-related death data, because I suppose ultimately that's what our fear is about, lack of control over dispensing. And also, it's so difficult to look at that data and interpret it in the context of a global pandemic as well. So although we've had this natural experiment of lots of take-home medication, we've had a very unnatural backdrop to that. You know, Catriona talked about disruption in drug markets. You know, we don't know what advice people had from the pharmacy setting, you know, around medication safety, we know what advice they had in the clinic, but, you know, it's quite an unnatural environment. But I think in terms of going forwards, we certainly in service I work in, we have maintained a lot of people on weekly takeout because we've no reason not to. They've done well, they're engaging better, they're grateful for the way services are delivered, and they're getting on with their lives. The focus or the priority has, as I mentioned, been about more effective key working and seeing if we can, you know, engage people that way. But there's certainly, you know, there are concerns around methadone-related deaths in the pandemic, and particularly amongst people not in drug treatment. But you have to unpick what's driving that, and then also it becomes a question of, if people in drug treatment are coping well, do you then restrict their freedoms for a group that are not coming to drug treatment? And there's a bigger question, isn't there? We all know about why people aren't coming into drug treatment, that we need to have answered and have, hopefully, going forwards, this reorientation of drug treatment to make it more appealing.
Thanks. Catriona, did you want to make a comment on that question as well?
Yeah, I will. Just some insights from Scotland to add to that. So Jenny mentioned data on drug deaths, and we do know that during 2020 in Scotland there was an increase in methadone being present in forensic toxicology in drug deaths. So there was some indication. What we don't know from that is, were people taking their own methadone, or was it, you know, fueling the kind of illicit market or methadone? That bit of the puzzle isn't there. But what is also evident from the data we did, and this qualitative data allows us to understand some of this, is by having that open communication and that link to key worker, when people are struggling and feel they need more supervision, they need to be able to ask for that and to have suitable response, but also the other way about. So, you know, it's really just building on that therapeutic relationship. And if that is strong, then people can say, I feel I would benefit from more supervision and going back, or the other way about, and hope that is kind of listened to.
Great, thank you. And we will keep popping your questions into the Q&A box or into the chat, because there will be a question and answer session at the end, but we do have one more presenter. Now, our next presenter, this is a pre-recorded presentation because he wasn't sure he'd be able to actually join us because he had other commitments, but he is going to be here, and I think he's actually here now for the questions and answers. So please, I'm really pleased to introduce Dr. Emmert Roberts' presentation, and please do pop questions for him into the questions and answers box, because we'll be able to put them to him at the end.
So, as I'm sure you all know, in March 2020, when COVID hit and lockdown was imposed, the UK government, as part of its policy response, enacted an initiative that was known as Everyone In. So it basically directed local government to temporarily provide housing, emergency housing, to those individuals who were rough sleeping within their areas. And within London, that at its peak over lockdown meant that the various local government organisations procured around 70 hotels, which housed about just over 5,000 people at its peak. The way these hotels were organised was they were all individually run by homeless sector charitable organisations, but they were designated into three different types. The first being COVID care, which housed people experiencing symptoms or who tested positive for the virus. COVID Protect, those who weren't experiencing symptoms or who were negative but had medical vulnerabilities to the virus, and then COVID Prevent, everybody else. And it was realised quite early on that there was a huge amount of substance misuse comorbidity among the individuals who were coming into the hotels. And so as part of the funding that was released to procure accommodation, funding was additionally released to create a new bespoke virtually run drug and alcohol service specifically for the population of the people that were in the hotels. And that's what became HDAS. We were initially commissioned for 3 months, and then obviously as things developed and as time went on, we were extended and extended and extended. And the service is still running today, albeit with one of my colleagues now very much in the driving seat and doing an excellent job. I'll just give you a little bit of an overview about what the service did, and then I'll come on and talk a little bit more about the specifics in terms of the challenges and the opportunities and the things that we learned. But we can really sort of split it into 4 different areas of what the service achieved, or didn't achieve in some ways. It was very much a learning experience. The first was providing clinical support. So we had a 24-hour initially, and then a 9-to-5 telephone and email line that professionals from the hotels could call us on to seek any advice or thoughts that they, or any worries or queries that they had about substance misuse. A lot of people were obviously going into self-isolation, and there was a lot of unplanned withdrawal from alcohol, opiates, and various other substances that people needed specialist support to be able to manage. So we had a telephone line. They could call us any time of the day. We also provided stuff, so harm reduction materials. So we provided lock boxes for people to store drugs in, naloxone, the antidote to heroin overdose, clean needles and syringes, distraction packs and workbooks for people to work through in their rooms, and also a variety of nicotine replacement products, including electronic cigarettes. We also provided some training. So a lot of the homeless sector charitable staff had not had any specific substance misuse training before. So over the course of about 6 months, we trained up about 65 people in how to deal with people who had substance misuse issues. And finally, because the service existed, it really just gave us a sort of place at the table, so that whenever any high-level discussions were happening among London government officials or within the public health system, it meant that we were able to represent substance misuse and explain how addiction perhaps needed additional thoughts or additional things to be done because of it. So I'm going to just run through a little bit about what we learned about alcohol, tobacco and drug harm reduction. And just to say that we've published a number of reports on this. The references of these are all available at the end, and I'm also very happy to be contacted or to take questions about it. So in terms of alcohol, before going into the hotel, we conducted some work to see what the level of need was out there, and alcohol was causing some form of negative consequence on about half of the hotel population's mental or physical health. So about 50% of the people were using alcohol harmfully. Alcohol was our most common subject of telephone and email contacts from hotel staff who were seeking advice and support about it. And it was the most common reason for new referrals that we initiated into specialist addiction treatment. So this is just a snapshot of our first 6 months of work. So out of 75 new referrals into treatment, these are people who are brand new to treatment, just over half of them were due to alcohol. And it was also the most commonly cited substance in the event of an individual being threatened with eviction from hotels. So just a little bit about some of the things that we did. So we realized very quickly that there were a lot of people suffering from alcohol dependence who may need to go in and self-isolate, or if they were testing positive or displaying symptoms. They obviously had no ongoing access to alcohol, and it was very difficult for us to manage detoxification programs from a virtual perspective, and we also didn't think it would be clinically appropriate. So we initially bought a whole bunch of alcohol. We prescribed and provided daily rationed alcohol doses to prevent the risks of unplanned alcohol withdrawal. We became very friendly with a lot of Uber Eats drivers who couriered a lot of booze for us across the city. You know, this is often typically termed a managed alcohol program, or using alcohol to manage people's withdrawals. And we provided sort of the first real world example of a successful managed alcohol program that was run completely virtually. Sorry, excuse me. So in this very unique context, our map secured a huge buy-in from a range of stakeholders, from hoteliers to homeless sector staff. There can often be resistance in providing alcohol to people who are alcohol dependent from a sort of moral standpoint among a lot of people. But actually, we managed to secure buy-in and from all people to prevent withdrawal and ultimately save people's lives. And it became a means of engaging people in discussions surrounding their alcohol consumption. And actually, people who'd never previously wanted to get into treatment, suddenly, is because we were providing them alcohol and keeping them safe, were able to engage in conversations around their alcohol use, and ultimately some of them access treatment. If we think about illicit drugs, so illicit drug use was reported by about 20% of the population, and it was responsible for just under half of our referrals into specialist addiction treatment in our first 6 months. These are the most common substances that we use. So opioids, the most common, followed by synthetic cannabis, cocaine, and herbal cannabis. And again, illicit drug use was also a commonly cited reason for individuals being threatened with eviction from the hotels. So what did we do? As I mentioned, we distributed quite a lot of physical stuff, so including lock boxes for safe storage of opioids, needle exchange packs to give people clean syringes for injecting, and about 100 kits in naloxone to prevent opiate overdose. These, again, were universally well received by most professionals and also by the residents in the hotels. We also were able, because of our links with local services, we were able to get people into drug treatment quickly and initiate rapid prescription of opiate substitution treatment for those wanting to enter treatment. A lot of our services shut down or became virtual over the course of the pandemic, but because we were working across London, we were able to slightly break down some of those barriers and get people quickly into treatment where they needed it. As I said, we provided training to about 60 members of homeless sector staff, and that included overdose awareness and how to administer the opioid antidote, naloxone. We also facilitated discussions with hoteliers who were quite reluctant to allow drug-using individuals, particularly into their hotels to start with. And we worked with law enforcement agencies in London to provide what we subsequently dubbed letters of comfort to hoteliers, that people wouldn't necessarily be prosecuted for Class A drug possession, which took some doing, but was very useful in the end. And finally, just thinking a little bit about tobacco. So tobacco cigarettes were smoked by about 80% of the population going into the hotel. Obviously, tobacco and cigarette availability was reduced during lockdown due to the closure of non-essential shops. And also people had less access to finances than they had previously. So there were significant reductions in begging and sex work. So a lot of people could no longer afford to purchase cigarettes or tobacco. Just as an aside, the United Kingdom banned tobacco smoking in closed public places from 2007, and so residents couldn't smoke in their hotel rooms, even if they were required to self-isolate due to symptoms of COVID-19 or testing positive. And as you might imagine, tobacco smoking was also a commonly cited reason for individuals being threatened with eviction or being kicked out for smoking indoors. So what we did was we sourced a bunch of tobacco harm reduction products, most notably about 3,000 electronic cigarette starter kits and refills, which we distributed to among the hotels alongside other nicotine replacement products. These were really, really well received by professionals, and it meant that people could vape indoors. It resulted in fewer evictions, and it meant that people could self-isolate while still getting nicotine, and they weren't then going out and potentially spreading COVID-19. So yeah, we've produced a report on the tobacco harm reduction stuff, which is referenced here. But yeah, the overall findings were that it led to some anecdotal reductions in residents breaking lockdown or self-isolation to buy tobacco, led to reductions in people sharing cigarettes or picking up stubs off the street, which obviously would increase their risk of COVID infection, and it reduced the risk of them being evicted. So just a little bit about breaking down barriers in terms of accessing treatment. Individuals who experience homelessness often access specialist drug and alcohol services and stop smoking services less frequently than those in the general population, though we know that they have a much greater need. They're typically referred to as sort of hard to reach, which in of itself can be quite stigmatizing language. However, there were loads of misconceptions both among residents and professionals about who was entitled to access drug and alcohol and stop smoking services. And these are some of the quotes that we heard over the course of the service. You know, I don't have any ID, I can't go to services. I don't have a fixed address, therefore they won't take me. I don't have a GP, I'm not entitled to receive care from a drug and alcohol service. How does my immigration status affect this? I don't want to risk being reported to government. I don't have any money. You know, I have no recourse to public funds. So this is a specific status in the UK whereby overseas visitors who have immigration difficulties cannot access publicly funded money or services. However, so our law states that drug and alcohol services are classified as primary medical services, and anyone can access them free of charge, irrespective of their immigration status or irrespective of their overseas visitor status. And so we produced these leaflets just to give you another idea of the kind of thing that we tried to do among this population. So these are the kind of leaflets that we shared among the hotels, just highlighting that individuals didn't need a fixed address, they didn't need identification, their immigration status didn't matter, you don't have to pay any money to access drug and alcohol services. Yeah, as I've said, they're freely available to overseas visitors. Services should never ask to see a visa or proof of immigration status as a means of determining eligibility in England, and an inability to provide identity or proof of address aren't reasonable grounds to refuse a person access. So informing people about these was key to engaging people and getting them to access services more during this period. So just a little bit about the funding in the future. As Dave said, the UK government has once again pledged to end rough sleeping by the end of this parliament, which is 2024. And so far, an additional £80 million has been invested in drug and alcohol services in what are being termed priority local authority areas with high numbers of people who experience rough sleeping. And whilst, you know, more money for drug and alcohol services is always very welcome, it should be noted that this is on the background of a £250 million disinvestment in drug and alcohol services since 2012. So yeah, as I said, the service has been extended until December 21. It looks likely it will be extended further, but we slightly watch this space. So here are my contact details, and here are some of the reports that we've published over the course of the last year about the work within HJAS and the work of everyone in. Please feel free to have a look at them or contact me with any questions. And thank you again for having me.
Thank you so much, Emmett, and I'm sorry there was a little bit of a jump on the video there, but I think the sound was very good, and we've certainly had quite a few questions come through, so hopefully it hasn't stopped people from taking on those important messages. We have had a few questions coming in. Actually, somebody's interested to know, was it the workers who were providing alcohol to people, or was it delivered by local delivery services? Someone's interested in how that part of the service ran.
Sure. Well, thank you very much for having me, Kate, and apologies to everyone for having to give you a recorded presentation of patients this afternoon. It really varied. So the healthcare on-site provision and also the provision of homeless sector staff workers within each of the hotels was incredibly variable. Some had very good on-site support, some had nothing, and there was everything in between. So we really worked quite flexibly. Where there were healthcare professionals or homeless sector workers within hotels, yes, we provided alcohol to those people and policies as to how they could calculate people's current alcohol intake, and on discussion with us, we matched them unit for unit if they were at risk of unplanned withdrawal. In places where there were fewer professionals working within those hotels, we were slightly more creative and used Uber Eats drivers to deliver alcohol on a person-by-person basis, so be it to professionals or be it to individuals. really trying any way that we could to prevent unplanned withdrawal and the complications therein.
Great, thank you. And I think it's also worth saying that that pre-recorded session was done just before we got the spending review announcements for drug services. So they have increased, but I think it's still worth pointing out that there have been massive reductions in spending over the past few years, and that I think that's been reflected in the chat. Catriona, I think there was a question around nasal naloxone, and I think you were interested in answering that.
Yes, I messed up on the question and answer function. And so, yeah, nasal naloxone, I think it's a great option as part of what we can make available, making sure that naloxone is as accessible to a wider group. And what we found is that there's certainly some people who are just more comfortable with nasal naloxone compared to the intramuscular injection. And it's because of intranasal that we're able now to have some police, carrying naloxone and trained to use it. We've also got a postal service for families and others in which nasal naloxone is an option. So I think it's a really good addition to the range. But what we really need to do is just get as much naloxone out there throughout the community of any form as we can.
Thank you. And this one is maybe for anybody who's interested on the panel in answering it. There have been quite a few comments around perhaps sometimes the gap between mental health services and drug services, and the fact that very often a lot of the issues that you're raising here could be dealt as well or better with mental health services. And I just wonder whether there's any general comments from the research you were doing or just general views on that.
Yeah, the people we spoke to, generally accessing other healthcare was difficult as well. I think Joe has said something in the chat, but we had people who had struggled to engage with the community mental health team or general practice. I don't necessarily think that was about the way maybe they were orientated. It was about this inability to, people already being disenfranchised and struggling at the best of times. It just made it harder. But yeah, don't get me started about mental health services for people with drug problems. It is a problem. It is a massive problem in helping people access the services they need.
I'd second that, and I'd also say that the problem and the barriers and the interface between mental health services and community drug and alcohol services is age old, and has been discussed and researched extensively over the time. What I would say is that the general principle of no wrong door is a very useful one to embrace. And if you get someone with a drug or alcohol problem coming through your door, please do not deny them access on the basis that they have a comorbid mental illness. Please do not deny them access on the basis that they have other illnesses. You can treat what you can treat in your services and advocate for your patients to be accepted to those other places. I know it can be a real barrier and also be very hard to do that. But excluding people from services and when they have a genuine treatment need is not the way to approach that. And I know we all desire to work integratively, and it's always put out there that integrated services work very, very well. And I think hopefully things may get better in terms of additional funding to reduce those barriers.
Okay, thank you. And I think certainly in the chat or in questions, people are saying they've experienced similar issues accessing primary care during the pandemic. And it's, you've already mentioned that, Jenny. I don't know whether anybody else experienced that within their research. We're getting all round nods, I think. Okay. Okay, what else have we got? There's somebody saying we've got services that have shut down buildings and people are still working from home, and it's very hard to access, for example, like housing. This has been a huge issue where homeless people don't have access to smartphones or to the internet, and therefore cannot access services. I think I saw that reflected in a few of your presentations. I don't know. I mean, again, it's a comment. It looks like everyone's agreeing. Whether anybody wants to speak further on that.
Maybe just one thing that did come out of our research, and certainly I think I've noticed in my practice, is completely agree with that point. But on the flip side, I've seen some great opportunities for innovation. I think probably we're working better with housing than we ever have done. We've got better communications with some of the other services. And moving on, you know, we've had things develop, like better outreach, better connection into hostels. So I completely agree, the whole digital poverty access thing is massive, but maybe we are starting to find a path and see some good examples. But, you know, that might just be a very local anecdotal observation.
I'm happy to come in as well, just on that digital aspect, because I think this is one of the really interesting areas coming out of the pandemic for all of us, is about digital, because before we were all very reluctant to kind of get digital. It was a bit of a turn-off phase for most of us. But now we know it's not that difficult, and it's not that, albeit a bit of a barrier for some people. So I think there's lots of opportunities to use digital technology and digital means. But it's not just the technology, it's also the training that needs to go around it. And that's for service staff as well as people who are, you know, service users, clients, etc. But there's great opportunity now, and I think we're going to see a lot more. I think in Scotland we've been lucky in that we've been able to get more actual devices out to people. I'm not sure that's happened to the same extent around other parts of the country, but I think it's more in pockets. But lots of potential, not just for linking people up to services, but also, you know, around information, around how you can minimise risk, responder applications for overdose, all sorts of things that I think we're going to see a lot more on now.
Thank you so much. I think, you know, the chat's been pretty active, and I think we're at the end of our time now. I mean, I'm just seeing some of the comments, lots of people saying they're having real problems having people access mental health services. Somebody thanking the panel for dealing with both urban and also rural issues, and really thanking you for giving such a kind of broad range of discussion in this webinar. So it just leaves me to say a really big thank you to the people who've been watching. We've had a lot of people on this webinar. Thanks for all the interesting discussion and chat and questions. And a really massive thanks to our panel. You've given us so much to think about and to reflect on for the next steps for services. So a really big thank you for your involvement in this webinar.